Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 437 of our pharmacotherapy series, which majors in breast cancer. The next case reads, STR is a 65-year-old, postmenopausal woman diagnosed with breast cancer at the age of 48 years. At the time of diagnosis she was premenopausal. She underwent surgery with a modified radical mastectomy and was found to have a 1.5 cm invasive, or infiltrating, ductal carcinoma of the right breast. She had 2 of 10 lymph nodes positive. Her breast cancer was estrogen receptor positive, progesterone receptor positive and HER2 negative. STR went on to complete adjuvant chemotherapy with AC therapy for 4 cycles followed by weekly paclitaxel for 12 weeks. After completion of her chemotherapy, she received 5 years of tamoxifen therapy. 10 years after completing her therapy, she experiences pain in her right arm and rib cage. A bone scan revealed metastatic breast cancer. So my question to you reads, what would be an appropriate treatment regimen for STR at this time? Early-stage breast cancer is curable. However, if a patient develops metastatic disease, the goal of treatment shifts from cure to palliation and stabilization of disease. Treatment is offered to improve quality of life and alleviate symptoms from treatment or disease. The mean survival time after diagnosis of metastatic disease is approximately 2 to 4 years. However, this can range from months to many years depending on the site of the metastases. The choice of therapy is based on the site of disease and other factors that help guide therapy, such as estrogen receptor and progesterone receptor status. Endocrine therapy is more likely to be effective in patients with bone-only disease, whereas chemotherapy may be used when there is visceral disease, i.e., liver or lung. Patients with organ involvement tend to have more rapidly growing disease that generally requires therapy with a quicker onset of action, such as chemotherapy. In addition to systemic therapy, chemotherapy and/or hormonal and/or biologic therapy, the clinician needs to determine whether or not local therapy, such as radiation or surgery, would be appropriate for a patient. Radiation therapy can be used to target painful bone metastases, to prevent further tumor growth, and to relieve pain. Surgery may be performed on bones with impending fractures, spinal cord compression, or brain metastases for palliation. These modalities of treatment only affect the local site of disease, so a combination of local and systemic therapy would need to be administered to fully treat the patient. If a patient is experiencing worsening symptoms such as shortness of breath, due to lung metastases or increased abdominal pain due to liver metastases, the use of chemotherapy may be preferred over hormonal therapy because of its quicker onset of action. Disease recurrence greater than 5 years after diagnosis illustrates a more indolent growing disease and is a favorable prognostic factor. Tumors with estrogen receptor and/or progesterone receptor positive characteristics would also be considered a good prognostic factor. Once therapy is initiated, response to therapy should be monitored periodically. Tumor markers such as CA27.29 and CA15.3 are commonly monitored in metastatic breast cancer. A clinical examination in combination with radiologic tests and tumor markers is assessed to determine response to therapy. Based on STR's metastatic bone disease and estrogen receptor progesterone receptor positive tumor characteristics, the use of hormonal therapy would be the most appropriate agent to initiate. STR received tamoxifen therapy in the adjuvant setting. Because she progressed after taking tamoxifen therapy, this would not be reinitiated. An aromatase inhibitor would be started because she is postmenopausal and should be continued until there is evidence of progression of disease via radiologic findings or increases in tumor markers. STR is started on anastrozole 1 mg orally daily. So my next question to you reads: what are other hormonal agents that can be used in the treatment of metastatic breast cancer? Hormonal therapy in the metastatic setting can provide long progression-free survival in patients. If the patient responds for an extended period of time, the likelihood of response to another hormonal agent is high. A patient may take multiple hormonal therapies before ever having to receive chemotherapy. As before, the decision regarding which hormonal agent to use is based on one's menopausal status. If the patient is premenopausal, the options include tamoxifen and luteinizing hormone-releasing hormone agonists. However, if the patient has received a selective estrogen receptor modulator in the adjuvant setting, this would not be used again in the metastatic setting. Aromatase inhibitors are indicated for use in first-line therapy in the metastatic setting for postmenopausal women. If an aromatase inhibitor is chosen as the first-line agent in the metastatic setting, use of another aromatase inhibitor after progression would include one from another category, i.e., non-steroidal versus steroidal aromatase inhibitor. For example, if anastrozole was used as first-line therapy for metastatic disease, then when the patient progresses, exemestane can be used. Many other hormonal agents are available for use. The pure antiestrogen, fulvestrant, is the only drug in a unique category of agents. It exerts its mechanism via binding and blocking of the estrogen receptor and down-regulates the number of estrogen receptors. Fulvestrant is administered as an intramuscular injection and is dosed initially as 500 mg on days 1, 14, and 28, then 500 mg monthly. It is approved for use after failure of tamoxifen therapy in the metastatic setting. This is an alternative for patients with compliance issues due to its once-monthly intramuscular dosing. Other hormonal agents used in metastatic disease are megestrol acetate, progestins, and high-dose estrogens. Higher doses have been found to inhibit cancer cell growth. These agents were used routinely before the approval of aromatase inhibitors. Now they are reserved for use after multiple hormonal therapy failures due to the toxicities associated with these therapies such as weight gain, vaginal bleeding, and thromboembolic events. Newer data have evaluated a class of drugs called the mTOR, an abbreviation for mammalian target of rapamycin inhibitors. These agents have demonstrated the ability to block resistance pathways of endocrine therapy. In the Bolero-2 trial, patients who had failed previous aromatase inhibitor therapy were randomized to everolimus 10 mg orally daily plus exemestane 25 mg orally daily versus exemestane plus placebo. Progression-free survival was statistically significantly better in the combination arm, but follow-up overall survival results did not demonstrate the same results. FDA approval was granted to this combination therapy in the metastatic setting after patients have failed a non-steroidal aromatase inhibitor. Another new class of agents just recently approved in the first-line metastatic setting for HER2-negative, estrogen receptor-positive patients is the cyclin-dependent kinase, abbreviated as CDK, inhibitors. Palbociclib, in combination with letrozole, was found to increase PFS in the Phase 2, Paloma-1 trial. Overall survival has yet to be determined, and a large Phase 3 trial is currently underway. This agent targets the inhibition of cyclin-dependent kinase 4 and 6 and inhibits cell growth and division. Serious side effects identified included neutropenia, pulmonary embolism, that is 3 patients, back pain, that is 2 patients, and diarrhea, that is 2 patients. STR was started on anastrozole therapy. She could have been initiated on any of the aromatase inhibitors. If her disease progresses, options include sequential exemestane, exemestane plus everolimus, fulvestrant, and then other agents such as megestrol acetate, high-dose estrogens, or androgens. The goal is to continue STR on multiple lines of hormonal therapy, as long as she is responding, before administering chemotherapy. My next question to you reads: in addition to anastrozole therapy, what other supportive care medicines should be added to STR's regimen? Patients with bone metastases are commonly treated with bisphosphonate therapy to decrease the risk of skeletal-related events, i.e., pathologic fractures, spinal cord compression, need for surgery, or radiation to the bone. Bisphosphonates act by inhibiting bone resorption. This ultimately will halt osteoclastic activity, leading to stabilization of bony involvement, prevention of fractures, and reduction in calcium levels. Bisphosphonates used are pamidronate 90 mg intravenously for 2 hours or zoledronic acid 4 mg IV for 15 minutes. Either of these agents can be administered once a month. Bisphosphonates are typically well tolerated, although they may cause nausea, increased bone pain, and fever. Reduced doses should be used in patients with underlying renal dysfunction. A more well-known but uncommon side effect is osteonecrosis of the jaw. The mechanism by which this occurs is not fully understood, but prevention is critical. If dental extractions or surgery is needed, patients should not be initiated on bisphosphonate therapy until these procedures are completed. If these procedures are required after initiation of therapy, an oral maxillofacial surgeon should be consulted. A more recently approved agent for use in the prevention of skeletal-related events in solid tumors is the humanized monoclonal antibody, denosumab. This therapy offers a unique mechanism of action, targeting the rank ligand, which is a mediator in osteoclast activity. Inhibition of osteoclastic activity by denosumab reduces bone pathology in osseous metastases. Denosumab has been compared prospectively with zoledronic acid in metastatic breast cancer patients and demonstrated significant delays in and prevention of skeletal-related events. Denosumab is administered as a subcutaneous injection and is given once a month. It has similar toxicities to zoledronic acid, but the dose does not require adjustments for declining renal function. Denosumab has been added to the American Society of Clinical Oncology guidelines for the prevention of skeletal events in metastatic breast cancer and other solid tumors. STR can start on bisphosphonate therapy with zoledronic acid 4 mg IV or denosumab 120 micrograms subcutaneously once a month to help prevent skeletal-related events. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 438.